coming well afterwards. And so now we're very thankful that she is joining us again today. This time with Living Organ Donation, Understanding the Donor's Journey. So Dr. Cockfield received both her undergraduate and medical degrees from the University of Toronto. After completing residency training in general internal medicine and nephrology in Toronto, followed by a research fellowship in transplant immunology in Edmonton, she joined the Faculty of Medicine at the University of Alberta. She is currently a professor of medicine and has served as the medical director of the renal transplant program and co-director of the Living Kidney Donor Program of Alberta Kidney Care North. So we are so thankful and we welcome Dr. Cockfield.
Unmute. Okay, are you able to hear me all right?
Perfect, thank you.
Can you see my picture on the screen? Yes?
Great, yes, looks great.
Okay, perfect. Well, I'm not sure the picture looks great, but the fact you can see it is a good thing. Okay. Now, so there we go. So what I was asked to discuss today was living kidney donation or transplantation from the donor perspective. The session I did in June was from the recipient perspective. So we're going to switch sides and review some information around the donor journey. So what I want to do is to start out by discussing the important role that living kidney donation plays in terms of transplant activity in Canada. And then I want to head down the road of exploring the risks and the benefits of being a living kidney donor. And I'll review for you briefly the process of being evaluated as a donor and how we make those decisions. So these next couple of slides are slides that I shared during the first presentation in June, but I just thought for those of you who didn't attend that session, it was important to understand that living kidney donor transplants are a major source of kidney transplants in Canada. Currently, they account for about 30 to 35% of all kidney transplants that we do in this country every year. So this certainly increases the access of patients to kidney transplantation. There are many benefits to the recipient, including the possibility of going straight to a transplant as they develop kidney failure, not requiring dialysis first. And even if they end up on dialysis, then the time to transplantation is much shorter. You can see in this data, for example, from 2017 to 2019, that the waiting time for a transplant on dialysis for a deceased donor kidney in Canada was 1,362 days, whereas those patients who had a living donor but already had started dialysis, it was less than 1 year. There are also reduced healthcare costs and reduced patient costs, partly because of the speed with which patients can get a living donor transplant. There's more potential for good matching between the donor and the recipient, particularly if the donor is within the same family. And that may mean there's a lower risk of rejection. Perhaps we don't need to use as much anti-rejection medications. And importantly, the outcomes are better for the recipient, both early and late. So there's absolutely no doubt that this is a tremendously beneficial treatment for the recipient. And of course, none of this could happen without the willingness of living individuals to donate a kidney, put themselves at risk in order to help someone that they care about, or perhaps help someone that they don't even know. So this might be a good segue into, I provided a couple of polling questions. The first one was, assuming you were healthy and had 2 kidneys and normal kidney function, what would you be willing to donate a kidney to someone that you loved or cared about? So I'm not sure if you run the poll from your end, but can you do that?
I will let Daisy please run the poll.
My apologies, Dr. Cockfield. I did not receive the poll questions.
They were in the form that I returned yesterday morning, first thing in the morning. Okay, well, that's fine, rather than wait for all of that to happen. So I just want you to think about if you were someone who had normal kidney function, had 2 kidneys, and were very healthy, would you consider donating a kidney to someone that you cared about? And the second part of that question is, would you consider donating a kidney to someone you didn't know, someone that you knew, or to a person who was sitting on the waiting list, but you had no connection to it all and never would have a connection? So I just want you to reflect on that a little bit. Okay, so are there really any benefits to the donor in being worked up as a potential living donor? It's easy to think about the risks, and we'll spend more time talking about that, but are there actually any benefits to being a living donor? Well, first of all, living donors do undergo a very extensive medical evaluation, and that could reveal undiagnosed health problems, some of which might do better if they were treated early. And in my time working with the Living Donor Program, I've made diagnoses of diabetes and high blood pressure in people who didn't know they had them, kidney cancer in people who didn't know they had it, hepatitis C that we were then able to treat successfully. So there definitely would be some potential benefits to that. Of course, having these diagnoses may have some downside as it relates to your future insurability. And so that's why it's very important that potential donors consent to being investigated as a donor, because we might turn up something that you didn't know about that might affect your future health or someone else's perception of your health. Are there any other benefits to being a living donor? Well, I think there is this sense of altruism. If you think about your life and how you've behaved in your lifetime, many people exhibit a really selfless concern for the well-being of others. Think of all those individuals who've gone and donated blood month after month after month to people who are going to get those blood transfusions, and they never know what happened to those individuals. There's just this sense that you've contributed. People who work on behalf of charitable foundations and to volunteer at various agencies or community support groups. Those are all things that you do because you have this sense of wanting to help someone. There may be also a sense of self-worth, knowing that you've done something that's been really important to someone else. So maybe you can give yourself a bit of a pat on the back by doing that. We can't ignore the fact that there may also be direct benefits to the donor. Imagine if you are the spouse of someone or the parent of someone, and you have the major caregiving responsibilities for that individual with a chronic disease. There may be significant psychosocial stress that a family member or family members live with in knowing that someone in their family has kidney failure. And of course, there may be the potential for an improved financial situation if the main breadwinner in the family is the person with kidney failure who may not be able to work or work full time as they are approaching kidney failure or on dialysis. So to be able to get that individual off dialysis and back to a more normal quality of life, better health, and the ability to work may have direct financial benefits to that family as a whole. So we can't ignore that there are some material benefits that may occur in some donor situations. The question really that we grapple with is, are those benefits of living donation for the donor sufficient to balance the potential risk to that donor? So you're going to hear over and over again through this talk, when we do a donor evaluation, this is all about the donor, the risk and the benefit to the donor. It's not about what is best for the recipient. And it's very important that we maintain that, because physicians and nursing professionals and people as part of this donor team are actually violating their oath to first do no harm. We are taking a healthy individual, we are subjecting them to surgery, which has risks, and the long-term risk of living with a solitary kidney. And so we are violating that basic tenet that we all said we wouldn't do, as we took our oath as physicians, the Hippocratic Oath. So it's very important that the donor team take the perspective of what are the risks and benefits for the donor and help that donor make the best possible decision. So the core ethical principles in medicine, I'm not going to go through these in detail, but just to highlight how we frame this in any area of medicine that is somewhat controversial. So the first is that we should have respect for patient autonomy, the ability of a patient or an individual to make their own choices. We should try and do good, help both the patients that we deal with and prevent harm from occurring to others. And we should maximize that good as much as possible. We should always work from the perspective of justice, where every patient in front of us has equal opportunities at potential therapies where appropriate. And finally, we have the obligation of to not do harm. And the problem is that some of these things conflict with each other. So in our respect for patient autonomy, we actually, when it comes to living donation, we have the potential, and in fact, we can do harm to living donors. So in this setting where the ethical principles conflict with each other, they don't align in the same direction in terms of decision making, it's really important to make sure that that we balance these risks versus benefits and our sense of how much harm we might be doing to someone. So the process of evaluating a donor really focuses on the analysis of risk versus benefit for the donor, not for the intended recipient, but for the donor, and ensuring that they have the appropriate information and can make a comprehended, informed consent. So often I see potential donors who made up their mind about donation before they actually even knew what it was about and what the risks are. And we need to take a step back and pull them back to the realities of what the potential risks might be and balance that against the potential benefit. Okay. So if someone is within a family or has within a friends or a community where someone is identified with kidney failure, the process of living donation really starts with the recognition that kidney failure is out there and perhaps in someone they care about. They have to understand that kidney transplantation is a treatment option for someone with kidney failure, and it's not necessarily for everyone with kidney failure. They need to know that kidneys can come from living donors, and that might be a possibility. Often people who are considering living donation will solicit advice from family members, friends, perhaps family doctors. They may go online and start doing their own research. And eventually they'll contact the Living Donor Program to explore the possibility of whether they could be evaluated as a living donor. And part of what we do initially is to provide some resources to help them with their decision making. We provide information about the process of living donation evaluation, the risks of that evaluation and the potential benefits, and the options for both for the recipient as well as for themselves if they have any concerns about proceeding. Patients can do online research. This happens to be the living donor website for My Health Alberta that was built by the transplant programs in both Northern and Southern Alberta. And so this is a great resource that you can walk through both as a donor and a recipient. Then they start their donor evaluation if they consent to proceed with that evaluation. And one of the first things we do is to try and make sure they understand the potential risks, both of the workup. Remember, I mentioned that we might make a diagnosis of something that could affect their health and their future insurability and how they view themselves as a healthy versus less healthy individual. So really important to ensure that there's comprehended consent to proceed with that evaluation. We want to make sure that the evaluation includes both medical and surgical considerations. So is this person who we're evaluating, are they a candidate for any type of surgical procedure? And then more narrowly, are they a candidate for this particular surgical procedure, the removal of a kidney for the purposes of donation? And finally, we need to evaluate what we think their future risks are of living the rest of their life with a solitary kidney. We also want to spend some time evaluating from a psychosocial perspective to look at motives for kidney donation, and I'll come back to this at the end of the talk, to evaluate competence to make an informed decision, to assess risk factors that might be associated with a poor outcome in terms of their psychosocial or mental health, and to look at resources that they have that can support them through the process of evaluation, donation, and recovery. And we also need to assess the potential financial impacts of being a living donor, having to take time off not only for the testing, but also for the surgical procedure and recovery. And so we have a donor team that does this, and that team includes a social worker and a physician. Those individuals must be separate from the recipient's care team. So there cannot be a conflict of interest with those two individuals where they get involved in both sides of the donor-recipient equation. And a coordinator it's recommended that the coordinator also be independent of the recipient team, and that is in fact mandatory in our program, although in some other programs that may not always be the case. If you are participating in a donor assessment, your duty is to the donor. It is not to find the best solution for the recipient. You are there to assist the donor in making the decision that is best for them. And this means that there's a very clear separation between the donor team and the recipient team. And I'm sure some of you who may have been through a donor or a recipient evaluation process may find this particular aspect very frustrating, and I appreciate that. But there is a very solid ethical reason why we need to keep the teams separate to allow decision-making that is best for each individual involved. Okay. We have to make sure we recognize potential conflicts of interest. I work for a transplant program. The view of others of the success of our transplant program may in part be dependent on how many transplants we do. I have to be very aware as a donor physician that my job is not to approve every living donor just so we can do more transplants and make the program look good, but rather my obligation is to the donor. We need to make sure that any individual who starts down this road has lots of opportunities to withdraw from the process if they feel that is best for them, or to pause the process if they need more time. And we have to ensure confidentiality of donor information. It's very important that donors are open with us about some of their concerns and about some of their behaviors that may have risk implications for them and the potential recipient. So they need to know they can trust us, that this information is not going to leave the donor team. So this is an example that I thought I would put up. It just so happens to be a patient with kidney failure, or addressing a patient with kidney failure due to polycystic kidney disease. Pure chance. I didn't actually know Dr. Caldwell was talking right before me. So this is a potential donor who contacted the program, a 37-year-old male. His brother has end-stage kidney disease due to polycystic kidney disease, is on dialysis. They're a compatible blood group. He had provided some screening blood pressure readings, and those of you who are in the know may recognize that these seem a little bit high for a healthy 37-year-old. He didn't have much in his medical history or psychosocial history, but he was the single father, or is the single father of 2 children who at the time were ages 5 and 10. And he's self-employed as a farmer. So as you look at this, you may recognize some points that we need to spend a bit of time on to decide whether this person might be suitable to proceed. We need to address the fact that there is a genetic kidney disease. Has this 37-year-old been screened for polycystic kidney disease? Maybe they have it themselves. And are they willing to be tested or screened? Because if they aren't, we're not going to really be able to proceed further. As I mentioned, the blood pressures look a little bit high. Maybe he's going to be left with a diagnosis of high blood pressure. Not only would that rule him out as a kidney donor for his brother, but it has the implications for his own health and some future insurability, that sort of thing. He's a single dad of 2 kids who are young enough that they need him. So Who's going to support him, look after the kids while he's in hospital? Who's going to do the grocery shopping when he can't lift more than 10 pounds for the first 6 weeks? Who's going to work at the farm? He's a self-employed farmer. So these are all things that need to be explored as this individual proceeds from a living donor perspective. So you can see we need team members that have multiple areas of expertise. It's not just a medical decision. This person, if they were going to be evaluated, would undergo extensive history taking regarding their past medical history, their social history with an emphasis on risk factors for infection, particularly of those infections that could be transmitted. So there are some very intrusive personal questions that get asked of every living donor about sexual habits, about numbers of partners, about IV drug use, all of that sort of thing. And those are necessary because we have an obligation to reduce the risk of transmission of disease. We spend a lot of time evaluating for symptoms or physical signs of various health problems like heart or lung disease, kidney disease, cancer, those sorts of things, as it relates to their suitability for donation. Their workup is going to include repeated measures of blood pressure, including the possibility of a 24-hour blood pressure study, lab work that looks at a whole variety of general things about their health. We spend time looking for diabetes because that's such a huge risk factor for future kidney disease. We want to know whether they have any evidence of kidney disease, and do they have kidney function that is normal and sufficient to allow them to donate a kidney. As I mentioned, we look for certain infections that can be transmitted to the recipient and need to be ruled out. We want to do some cancer screening because cancer could be in the kidney, and we want to make sure that's not transmitted to any potential recipient. And we do imaging to make sure people have 2 kidneys, that they look like they're pretty equal. Eventually, we'll do some imaging of the blood vessels to and from the kidneys to try and decide which kidney may be the suitable one if people get far enough down their evaluation to get to the point where we think they'll be able to proceed. So I started by describing some of the benefits of being worked up as a donor, but what are the risks? Because that's the thing that we grapple with the most. And I have to say that I like to evaluate people who are in their 60s as potential living donors. Those people have gotten to the age of 65. They haven't developed high blood pressure, or else they have blood pressure, it's hypertension that's very easily controlled. They've not developed diabetes. They've got to 65 in very good health. Yes, the risk of surgery itself may be higher because they're older and more likely to have heart disease that maybe we don't find. But on the other hand, I don't have to predict what's going to happen to them in the next 10 or 20 or 30 years, or my ability to predict is much better than if I'm evaluating a 20-year-old. Do I really know what that 20-year-old is going to be like from a health point of view? Sorry, a second. Sorry about that. Do I really know what that 20-year-old's health is going to be like after 60 years of living with 1 kidney? So there's a lot of uncertainty, and we have a limited ability to predict some of these future events. So there's obviously the risk of the actual surgery, what we call a donor nephrectomy, the removal of a kidney for the purposes of donation. There are long-term risks of living with 1 kidney. There's psychosocial risks of undergoing surgery for the purposes of helping someone else. And there's financial risks for the donor. And so what are those risks? Well, in terms of the actual surgery, this is not a high-risk procedure as surgery goes, but it's not zero risk. You can see that the risk of death due to having right around the time of kidney donation, so limited to the surgery itself, is about 3 to 4 deaths out of 10,000 donors. That's not too far off the risk of a woman dying during a C-section. And you can compare it to the risk of dying in a car accident after you drive 10,000 miles, not all at once, but cumulatively. where the risk of dying in a car accident is estimated to be 1 to 2 out of 10,000 drivers. The risk of dying with kidney donation is 3 to 4 deaths out of 10,000 donors. But it's not zero. And remember, these individuals are volunteering to undergo a surgical procedure that they do not need for their own medical health. They might need it from their psychological health, but not for their medical health. And that's when we usually do surgery. There are some serious life-threatening complications that can occur in up to 30 to 40 out of 10,000 donors. These are things like having a heart attack or a stroke around the time of the surgery, developing a blood clot, and that clot could potentially move to the lungs, life-threatening bleeding, or a very deep infection that requires much more extensive surgery and workup and treatment, and can be life-threatening. And then there are very common surgical risks. Everyone has pain after they donate a kidney, but about 5% of them will continue to suffer some degree of pain in the long term. It may only be when they move or stretch in a certain direction, but for some people, it's often and frequent enough that it actually may prevent them from returning to work. So we need to consider that. Postoperative nausea or vomiting is very common. Wound infections or bladder infections can occur in 5 or 10% of donors. Pneumonia can occur in about 5%. Some people will develop a hernia at the site of their incision. That's much more common with the old style of surgery, less common now. And many people will have some numbness around near the incision site that may get better, but it may never go away completely. And of course, you're left with a scar 100% of the time. The thing that I think kidney doctors worry about most are the long-term risks of having just one kidney for the rest of your life. We worry about the risk of developing high blood pressure when you're working with just one kidney, of the fact that you will have lower kidney function after you've given one kidney, and what is the risk of developing kidney failure because you've donated a kidney. And so these are very real things that we spend time talking about. We know that blood pressure rises a little bit on average with kidney donation. So if someone is very close to the threshold where they would be diagnosed with high blood pressure, we may push them into high blood pressure with kidney donation. We know that a little bit of protein in the urine can occur in about 10 or 20% of donors. This typically doesn't get worse, and it's not necessarily associated with any progression in terms of loss of kidney function in the long term. The thing that we worry about the most is the loss of kidney function. You might think that when someone gives up one of their 2 kidneys, that they will lose half their kidney function. For most donors, that's not true. In fact, the remaining kidney becomes much more efficient. And as a result, the average loss of kidney function is about 30%, but it can range from 25% to about 40%. Older kidneys have less ability to adapt to that loss of kidney function with donation. And so they're probably closer to the 40%, whereas young people, particularly people in their 20s, may actually be left with only a 20 or 25% reduction in kidney function. The big thing that we worry about is what is the chance that this kidney donor will eventually go into kidney failure themselves, because we're removing some kidney function. And in most situations, if you lose kidney function, that's a bad sign in terms of future risk for dialysis. And this might seem strange that we've been doing this for more than 30 or 40 years, but it's really been only in the last decade that we've actually had better quality data around this. And there is no doubt that the average kidney donor is at higher risk of developing kidney failure themselves by donation when they compare themselves to healthy individuals who choose not to donate. That risk is somewhere between 3.5 to 11.5 times greater by choosing to donate. It's still lower than the average person out on the street, but of course the average person out on the street may not be a healthy person. They may have kidney disease themselves. They may have high blood pressure or diabetes. They may be morbidly obese. They may have all sorts of things that could affect their kidney health in the long term. But when we narrow that general population out on the street to the healthiest group of people and compare the risk of kidney failure, they have a lower risk of kidney failure than the people who proceed on to kidney donation. So this is a very important thing for donors to understand. There's certain donor characteristics that we look for that increase the chance of ever needing dialysis. And those would be Black race, obesity, the development of high blood pressure or diabetes, and also donating to a first-degree relative, so parents, siblings, children. And that's probably because of the genetic predisposition for some forms of kidney disease, where maybe it's not evident in this donor we're evaluating, but they bear that risk, and it may eventually come to fruition that they themselves have a higher risk of kidney disease. So this is illustrated in this particular study. This is a big American study. This study's actually led to the generation of a risk calculator that we can actually use when we evaluate donors. What it shows you is that if you take the healthiest part of the general population and they donate, and you were to start at age 30 and look at what happened to them over the next 50 years, there is a low risk, even in that very healthy group, that some of them will develop kidney failure and need dialysis or a transplant themselves. It is a very low risk, but it is not zero. If you compare unselected individuals, people pulled off the street, and looked at all of their risk for developing kidney failure over 50 years, you'll see it's up in this range, around 340 per 10,000 people. And here's where the living donors are. So these are healthy people who gave up a kidney. And over 50 years of follow-up, some of them will develop kidney failure, and that risk is higher than if they had chosen not to donate. And so in this article, they provided this illustration that if someone donated at the age of 30 or before the age of 30 and they were followed till the age of 80, the risk that some of them would develop kidney failure was 90 per 10,000 donors. When you compare that to that healthy group of people who chose not to donate, it's only 14 per 10,000 donors. But both of those numbers are significantly lower than the 326 per 10,000 donors in an unselected population. So this is something that potential living donors need to understand. If their goal is to have the lowest risk of ever needing dialysis themselves, they should not donate, because they are increasing their risk of having that happen over decades of follow-up after they donate. We also know now that the risks of pregnancies that occur after donation is a little bit higher than it is for pregnancies before donation. There's a slightly higher risk of developing high blood pressure during pregnancy. Sorry, I'm sure these are politicians calling my phone. I'm sorry about that. So there is a bit more hypertension in women who have previously donated a kidney and then find themselves pregnant. But the risk of that is not much different than the risk of women who become pregnant who already have high blood pressure or diabetes or are obese when they become pregnant. So young female donors, donor candidates, need to understand that that is also a risk they have to consider if they have not yet had their family. And so, and we try and inform family physicians of that as well, as part of our donor evaluation. We also need to think about the effects of quality of life of kidney donation. There is a risk of disability if someone has a long-term complication. There's a lot of anxiety around the donor evaluation. Will they be approved? Will they not be approved? There's anxiety around having surgery that maybe some of our donors have never had surgery before. So it's a very big deal. And of course, there is a risk that if things go badly and either the recipient doesn't do as well as you think, or God forbid, they don't look after the kidney, or it fails, or whatever else, there's a risk of depression following donation. It's a very emotional time for donors. And so some people will really struggle with that. And fortunately, suicide has not been reported commonly. The majority of donors do not regret their decision to donate, and if they had another kidney to give, they would. But there are a minority of donors that do experience significant psychosocial distress after donation. The strongest predictors of that, of people who were ambivalent to start with, maybe they felt they had no choice. There was so much pressure from the family or from the recipient to go ahead and donate that they did it even though they weren't really sure it was the right decision for them. People who decide to donate to atone for past wrongs or to elevate their status in the family usually find that doesn't actually work. And so not only have they given up a kidney, but their situation hasn't really changed that much. And so that is associated with poor outcomes. And so a careful psychosocial evaluation is a mandatory part of our donor evaluation. And we can call upon not just our social worker who's part of the team, but also psychologists and psychiatrists who have experience in this area. And we need to think about financial risks. There are expenses incurred during the donor evaluation. You may need to travel to a center to get a specialized test that can't be done in your local lab or imaging facility. And of course, there are perioperative expenses. There's loss of income as you're recovering from surgery. And some people worry about job security, that the job won't be there when they're ready to go back to work, or that it'll be all too easy for them to get laid off because they're off for several weeks already. And we have to think about future insurability. Although insurance companies say that they do not discriminate against previous kidney donors, it's very hard to get concrete evidence. And I've heard donors tell me that when they first called, they were told that they wouldn't be insured or their premiums would be higher. Obviously, that should never happen. And we do have a donor reimbursement program, which can help with some of the costs, but it can't replace all of the income that might be lost. So it is important that donors understand there are some potential financial risks. So what I've tried to do in this period of time is to discuss the importance of living kidney donation as it relates to transplant activity and access to transplantation in Canada, to highlight the important goal of a living donor evaluation, which is to determine the risks and benefits, the balance of those two things to the donor, not to the recipient. The evaluation is multifaceted, time-consuming, and pretty in-depth. I think people are often surprised by how much we actually do in a donor evaluation. It's impossible to make living kidney donation risk-free. Our goal is that with careful screening and selection of appropriate individuals, we can reduce the risk of poor outcomes, both in the short and the long term. And of course, I have to pay tribute to the living donors who make this happen. And these people are heroes in my mind. It's a privilege to be involved in their care and to evaluate them. And I have the highest respect for people who put themselves at risk to help someone, not just someone that they know and care deeply about, but some of those donors are donating to someone who's on a wait list and they don't know who that person is, and they will never know how they do with the transplant. And all living donors are exceptional individuals for making that commitment.